In class this morning, we skipped from the transthoracic Lawrence method down to the scapular Y view because there's some specifics about the Y view that I wanted to communicate, some of which really aren't touched well on the test and where we can use the Y view instead of the transthoracic. So I want to go ahead and show the slides. I drew the Y view out on the board and talked about where we could make a diagnosis with the Y view as opposed to other views. We'll cover this and then we'll back up and we'll talk about the other Lawrence method, which was the inferior superior axial. So the Y view is named because it actually looks like a Y, and we'll take a look at some images here in a minute. But the position is really useful to diagnose dislocations, fractures of both the humerus and of the scapula. And so it's an extremely versatile view of the shoulder and the humerus. So you can position the patient upright or with them laying down. Generally, if they're laying down, you're going to be shooting AP. If you're upright, you can shoot AP or PA. Most technologists, in my experience and in the Tyler area anyway, shoot theirs AP, which means that if you use the PA, then you're kind of the odd man out. And certainly that applied to me when I was in clinical practice. So if you shoot yours PA as opposed to AP, it might be a good idea to mark the image so that the radiologist knows which which Y view that you actually performed. Otherwise, it may look like it's backwards to him, and it looks to him like you mismarked your image. So upright or recumbent, again, consider shoulder pain. It's going to be painful for the patient to stand upright if they're already recumbent or to lay down if they're already upright. So consider their positional pain and whatever body position they're in, be it in a wheelchair or standing up. Just go ahead and shoot them upright instead of putting them on the table. If they're on a bed, just go ahead and put them on the table instead of standing them upright. So the description here is anterior oblique, which would follow with this positioning. So if you're shooting posterior obliques, that would be a right anterior oblique position. PA projection. So your affected shoulder would be closer to the image receptor. This is the first place we're going to run into a range of obliquities. So it could be 45 degrees, it could be up to 60 degrees, depending on what your patient's anatomy looks like. So you're going to palpate the scapula and put the flat surface perpendicular to the image receptor. The arm position is not critical. I kind of disagree with that. The arm position is somewhat critical if the patient has scapular pain and you're looking for a fracture of the scapula. You really need to get the shoulder out of the way, or you need to get the humerus out of the way so that you can see the scapula itself, the lateral of the scapula, without superimposition by the humerus. Again, there may be some positional pain there, so you can move it as minimally as possible just to get it out of the way. So central ray is going to be to the scapulohumeral joint space, that is your glenoid fossa. Your collimation is going to be 12 inches. Your image receptor is going to be lengthwise, or your collimated field is going to be more long than what it is wide. On your image, what you're going to look for is evidence of proper collimation. You should see collimation on the image receptor, but you shouldn't collimate so tightly that you collimate required anatomy off the image receptor. Remember, you need to see the entire glenoid fossa. Yeah, that should be in the middle of your image, but you need to see the acromion and the coracoid process as well. So the acromion is going to be projected laterally and free of superimposition. The coracoid process is going to be medial. The scapula is going to be in lateral profile. And what bony trabecula can be visualized, should be visualized. Humeral head will be seen in the middle of the Y, right at the glenoid fossa. If it's not over the glenoid fossa, that's either because your rotation wasn't proper or you've got a dislocation. Remember, 95% of your dislocations are going to be anterior dislocations. And I'll show you on the image where that's going to manifest. So it should look like that. This is the body of the scapula. And look how hard it is to visualize because the cortex of the humerus kind of blends in to the body of the scapula. So what you're looking at there is what looks like a solid bone with just some overlying features inside of it. So if you've got a fracture that's going across the scapula, if it's a non-displaced fracture and it's just cracked, you're just not going to see it very well with the humerus in the way. So you need to get the humerus out of the way. What you see here, that is your AC joint. So this is the acromion, and that would be the coracoid process. So the Y is right there. So it's good positioning, especially if our positioning is for the humerus. We can see the cortex of the humerus, so if we've got a fracture, we should be able to visualize that. But if we've got a fracture of the scapula, it may be very difficult to see. So if we have a dislocation, what happens is that it pops out anteriorly and it shifts a little bit medially. So what that means is that, and inferiorly. And so what that means is the humeral head's not going to be over the glenoid fossa, it's going to be over the ribs right there. So most of the time, I've never seen a posterior dislocation myself. So most of the time, that's where your dislocation is going to be seen. If it's a posterior dislocation, it's going to be out here. So that's a very beneficial position and projection to use to visualize all of the anatomy that we just spoke about and pathologies as well. Again, you can reverse everything that we just talked about and shoot them AP, and really the only difference is going to be that the perceived size of the scapula is going to be quite a bit larger. It's going to take up most of a 10 by 12 collimated field. So your collimated field may need to be just slightly larger because of the magnifications that will naturally be present if you shoot AP. So then we'll move on to the other Lawrence method, which is what a lot of people call the axillary view. You don't hardly hear anybody refer to it as the Lawrence method in clinical practice because Lawrence is pretty much all over the place in positioning textbooks. So to keep from having to clarify which Lawrence method that you're referring to, in a lot of cases people just refer to it as the axillary. On the axillary position, what you will need to do, unfortunately, is go ahead and lay the patient down. So they're going to be supine. I tried to do these upright, tried to experiment and get a upright Lawrence method, and it never worked out. So go ahead and lay the patient flat on the table. If the patient's on a stretcher, you can go ahead and shoot on the stretcher. It's going to be a tabletop view anyway, so the patient can be shot on the stretcher. So what you're going to have the patient do is turn their head away from the central ray. So have them, if let's say you're taking an axillary view of the right shoulder, the patient would be looking as far as they can to the left. You're going to abduct the humerus, if they can, all the way out to 90 degrees, so it'll be at a right angle. Placing the arm in external rotation, and that's really kind of a natural position to have the patient in. And you can have the patient bend their elbow and hold the image receptor into place if you don't have some sort of support for the image receptor. If the patient can't tolerate that, or if they, for whatever reason, can't bend their elbow or hold the image receptor, then you're going to need some sort of image receptor stand or sandbags, maybe tape. So your central ray is going to be at an angulation of 15 to 30 degrees medially. So the further they can abduct their humerus, if they can get it out to to 90 degrees. You're going to use a 30-degree central ray angulation. Um, so the x-ray tube is going to be at a distance from the patient's body, angled inward towards the shoulder. So if this line that I'm kind of drawing up and down here represents the patient, at 30 degrees, it's not going to be quite 45 degrees, but it's going to be a steeper angulation. Whereas if the patient cannot abduct their humerus quite as far, maybe they can only abduct their humerus to 45 degrees, instead of 90 degrees, you're going to use a shallower central ray angulation. So again, the patient's body is here, your central ray angulation is going to be more like about that. So it enters the axilla and it passes through the AC joint. So again, the angle depends on the abduction of the humerus. More abduction, greater angulation. Your central ray is going to be a 10 by 12 image receptor with the 12-inch measurement going parallel to the humerus. Again, granted, the patient can abduct their humerus that far. So we're going to look for evidence of proper collimation. We're going to look at the scapulohumeral joint space. You got a slight overlap. I'll point out where the coracoid process should be, but it should look like it's coming basically out of the glenoid cavity. But it should be pointing anteriorly. You should see the lesser tubercle in profile, the AC joint and acromial end of the clavicle should be projected through the humeral head, and I'll point that out as well. And then again, bony trabecular markings. So what you should see, this is glenoid fossa right here. Let's see if I can blow this up a little bit and make it a little bit easier for you to visualize. Well, that's not the one I wanted. This is the one I wanted you to see better. Okay. So really the coracoid process should be a little bit closer here, but it should look like it pretty much rises straight out of the glenoid cavity. So you got the glenoid cavity here, and it should come up, maybe a little bit of a transition, and then the rise of the coracoid process. And here's the kicker. If you don't have the patient not only turning their head is really to reduce eye dose, but if you don't have them turn their head in the opposite direction and tuck their chin, sometimes you can't get the image receptor far enough into their neck in order to get the humeral head. So the textbook says, and the PowerPoint says, turn their head, but I'm telling you, have the patient turn their head and then tuck their chin to enable you to put the image receptor further into the patient's neck. So that's your glenoid fossa, that's your glenohumeral joint space, and your coracoid process is here behind the humerus, and that's really what it should look like. So I referenced AC joints in class this morning, but I didn't get around to it. So AC joints are your acromioclavicular joints. On the Y view, it would be this area right up in here. And whenever you hear of, let's say, a football player or some sort of athlete that separated their shoulder, what we're really talking about there is not dislocation of the humerus itself from the glenohumeral joint space, but rather separation of the acromion from the clavicle. The AC joint is this dark line right there. So it's a fibrous joint space that permits some motion, but it's not like a diarthrotic joint space that permits free motion like what the ball and socket joints allow. So separation of those two, very painful, and it disrupts that fibrous connection between the two. So a few things, important things to remember about AC joints. First off, you're not going to be able to do these with the patient laying down without patient cooperation. So almost always these are going to have to be shot upright. So again, if a patient comes to you and they're on a stretcher, set the head of the stretcher up before you try to get the patient off of the stretcher and standing. You may have to shoot these images with the patient on the stretcher itself or seated in a chair, one of the two. So what you're going to do is you're going to shoot bilateral, meaning both sides. So you're going to use a single image receptor to take an image all the way across both acromioclavicular joints. So the arm is going to be hanging to their sides, unsupported, shoulders in the same horizontal plane, and you're going to make two different images. You're going to take two different exposures. One with the patient just relaxed, and the other with the patient holding on to weights. So what we're trying to do is we're trying to exaggerate that separation between the acromion and the clavicle. And how we accomplish that is by having the patient hold on to weights. The amount of separation between the two can be graded from 1 to 4. A level 4 separation means that you've got a total disruption. There's really nothing connecting the two anymore. So what you're going to do is get the patient upright. This is the only upper extremity view that you might shoot at 72 inches. So get the patient upright, put your image receptor in the wall bucky, and if you're using a rectangular image receptor, your image receptor is going to go in crosswise so that you can take advantage of the full length of the image receptor. Back up to 72 inches so that you have less divergence of the central ray and you're less likely to project those off of the image receptor. If you pay attention to chest x-rays, taken at 40 inches, what you'll see in a lot of cases is the shoulders will be projected off of the image receptor at 40 inches. So I recommend you back up to 72 inches. So get the patient upright, image receptor in, collimate down to just an area that would include the AC joints. So your collimation is going to be thin, but it's going to run the entire width of the image receptor. And shoot one without the patient holding any kind of weights. Then what you will do is give the patient something to hold. Now, the textbook says that if you use straps and attach the weight to the straps and attach the straps around the patient's wrists, then they have a tendency to allow the weight to pull down better than if they're holding them in their hands. If you hand somebody something heavy to hold, then they have a tendency to use their shoulders and pull against that weight. Whereas if it's attached to their wrists, in a lot of cases, they'll allow the weight to pull their shoulder down a little bit more. I've never worked in a hospital that had any kind of wrist straps for AC joints. So if you have those available to you, then great, use them. If you don't, then you need to educate your patient. You need to tell them, hand them something heavy. Every hospital I've ever worked in just used barium jugs. Hand them the barium jug and say, tell them that you want them to relax their shoulders and let the barium jugs pull their shoulders down. It's going to hurt, so you need to have everything set up before you hand them the weights. The last thing you do is hand them the weights, trot back, make your exposure, and tell the patient immediately they can let go of the weights. So what you're going to see with AC joint separation, if I scroll back up to AP of the shoulder, this is no separation here. You've got good contact between the acromion and the clavicle. But what will happen is if they've got let's say a level 1 separation, you can't really tell the difference between a level 1 separation and no separation just by looking at one shoulder. The reason we look at both of them in a single image is so that we can make a comparison between the two sides. So if there's a slight separation on one side, slight deformity on one side compared to the other side, maybe this side drops down just a little bit, but a mirror image on the opposite shoulder looks more like this, then what we could say is that the patient has level 1 separation. Level 4 separation is obvious. The clavicle is sticking up here, and the acromion is way down here somewhere. So the central ray is going to be perpendicular to the midline of the body. Basically, it's going to be shooting right through the center of your vertebral column, and perpendicular to individual AC joints. If separate images are required, there's really no reason to shoot separate images. A single bilateral view with a collimated field of about 6 by 17 inches should do well. So make sure you collimate. You don't need the entire 14 by 17 projected field. You want to make sure that you see both AC joints. Again, you may have to back up to 72 inches in order to visualize that, with and without weights. Have the patient hold their breath before you make the image. You don't want any kind of rotation or have the patient leaning, which is going to be a tendency. If their shoulder hurts, they're going to have a tendency to slouch. Just, again, educate your patient and make sure that they don't slouch. Make sure that you mark your images as weighted and unweighted so that the radiologist can tell the difference if there's any kind of question or if there is no joint separation at all. And if there is a joint separation, then what you should be able to see is the evidence by comparison between the weighted and unweighted, and between the side that's injured and the side that's uninjured. You should be able to make that diagnosis, or the radiologist should be able to. So here's what we're looking at. So single image all the way across. This actually could have been more collimation. Could have been used on this image. This is a young patient. So you can see a little bit of a difference between the two sides. You've got good contact between the acromion and the clavicle here, as opposed to over here we've got a little bit of an elevation. And that would be what we're looking for to make a diagnosis of a separated AC joint. Clavicles are the last thing that we're going to talk about. We've got a few different views of the clavicle. Again, they're really going to be essentially 4 views of the clavicle, but they're really the same views. So we've got AP or PA, AP axial or PA axial. The rule of thumb for 2 views 90 degrees from each other kind of fails in the clavicle. You can't get a good view of the clavicle 90 degrees from AP or PA. So the AP axial or the PA axial is going to be as best we can get to 90 degrees from each other to make that diagnosis. So I'll use the same collimation. You can collimate down to just the clavicle itself, but in a lot of cases people use a collimated field a little bit larger than the clavicle alone at 8 by 12. The top of the image receptor should be about 1.5 inches above the shoulders and 1 inch beyond the lateral aspect of the shoulder. You need to include the entire clavicle all the way to the midline. And by midline, I mean the sternoclavicular joint. So patients can be upright or supine. The clavicles should be centered to the image receptor. The clavicle of interest should be centered to the image receptor. The arms at the patient's side, shoulders in the same plane. Central ray to the midshaft of the clavicle. Make the exposure at the end of full exhalation. So have the patient blow all their breath out and stop breathing. And what that does is it takes the air that's in the lung and it kind of compresses it so that what we wind up with is a little bit of a more even, it doesn't compress it, I'm sorry, compresses the lungs by virtue of not having the air in them. So it evens out the tissue density differences that would exist between the clavicle that's over the lung and the clavicle that's over the soft tissue. So that's AP. PA is just the reverse of that. Most of the time, if you get the patient on the table, you're going to shoot AP. I've never seen anybody shoot a PA clavicle with the patient prone on the table. So if the patient's upright and you feel like shooting a PA clavicle, you can shoot the PA clavicle. It's going to be a either or situation between the AP clavicle or the PA clavicle. The PA clavicle puts the clavicle closer to the image receptor, so you're not going to have quite as much magnification. In all honesty, I've never seen anybody shoot a PA clavicle. I'm not real sure why. It may just be because the axial is almost always going to be AP. And it just might make more sense to people to shoot AP and then AP axial rather than PA and then follow that up with a PA axial or AP axial. So, same positioning basically, only PA as opposed to AP. So what it should look like is this. We've got about a third of the clavicle that's going to be under the ribs and under the lungs. And then we've got the rest of the clavicle out to the side. So since we can't get 90 degrees from that, what we're going to have to do is just get a different view that would show us some degree of three-dimensionality. So we can diagnose exactly where the displacement is in the event that we have a displaced fracture. Central ray angulation for the axials is going to be dependent on patient position, whether they're standing or seated or supine, and also on their body build. This is not necessarily referring to body habitus, but rather how thick the chest is. So if you've got a patient with a big barrel chest, even if they're not hypersthenic, then what you're going to utilize is a lesser angulation. Somebody who's got a very thin chest is going to need an increase in angulation. What we're trying to do, look down at the image, what we're trying to do with the axial is to project as much of the medial portion of the clavicle above the ribs and lung field as possible without so distorting it that it becomes undiagnosable. And what I mean by that is you can increase your angulation enough to get this medial end of the clavicle completely off of the ribs and the lung, but in that angulation you create such an angulation that, or a distorted image because of the angulation, that you can't make a diagnosis. So we're going to angle 15-30 degrees with the patient upright, more angulation if the patient's got a thin thoracic cavity, less angulation if the patient has a thick thoracic cavity. So you can also have the patient lean back in a lordotic position up to 15 degrees to accomplish the same thing. I really don't recommend you do that. Leaning the patient backwards is going to be very, very painful for the patient. If you do try this, what I would recommend that you do is put the patient in a chair that has a back on it, not on a rolling stool, but in a chair that has a back on it so that the patient can lean back and still be supported. So a supine position is going to be a 15-30 degree angulation based on the same things. If you got a patient with a thick chest, it's going to be a 15-degree angulation. If you got a patient who's got a thin chest, or a patient who might not necessarily have too thin of a chest but has a natural lordotic curvature, then you may need to increase to 30 degrees cephalic. Central ray again is going to be to the mid shaft, and you're going to make your exposure at full inspiration. The PA clavicle, we're just going to reverse the angulation. Instead of a 15 to 30 degree cephalic angulation, what we can utilize is a 15 to 30 degree caudal angulation. Remember, anything that you can shoot AP, you can shoot PA. Anything that has an angulation and you shoot AP, you can shoot PA just by reversing the angulation. Entrance and exit points are going to change as well, but the most important thing to remember is that you reverse your central ray angulation. So again, evidence of proper collimation, lateral 2/3 of the clavicle is going to be projected above the ribs, clavicle in horizontal orientation, as opposed to seeing that double curvature is going to be more flat. The entire clavicle, along with the AC joints and sternoclavicular joints, are going to be visualized. and you should see the trabecula, and you saw the image before. Here are two different images of the clavicle. One is the AP and one is AP axial. And even though you don't see a whole lot of difference between the two, you can see a little bit of information on one that you just would have missed had the axial not been performed. We can tell that this is the AP based on how low the clavicle is. So we got the first rib, second rib, third rib, fourth rib, just like on a chest x-ray. Clavicle's at the fourth rib. So we can see an obvious fracture, and they tend to fracture pretty sharply. And if I open the other one, then we can see this little piece of fracture that came off. Now if we look, we see 1, 2, so it's between 2 and 3, the second, third rib. So this would be the AP axial, and we can see not only the fracture, we can see a little bit more of the clavicle, and we can see this little piece that broke off of the clavicle as well. There's even a possibility we got a little bit of a separation of the AC joint. The clavicle, whenever it's solid, would be more in contact with the acromion, but with a fracture there, it's kind of stretched out just a little bit. So we've got maybe a slight separation there. We don't know if that will heal back up once the clavicle heals, if that'll kind of cinch up a little bit, or if that will be a chronic condition. We just can't tell from this image. So there are views of the scapula. We already talked about the Y view. The Y view, remember the positioning for the scapula for fracture of the scapula versus fracture of the humerus. Just involved a matter of moving the humerus, but the lateral scapula is a Y view. That's all it is. It's Y view with the humerus out of the way so we can see fractures of the body of the scapula. So the AP of the scapula is really the only thing that we're going to talk about in depth, and that would be with patient either upright or supine. Same rules apply, positional pain. And you're going to center the affected scapula to the image receptor. One thing I should have pointed out earlier, once we get to the humerus, we start to get to an anatomy thick enough to consider using a grid. Remember, we have two rules for grid use. If we use a KVP that's above 70 KVP or anatomy that's 10 centimeters or above, we really kind of need to use grid. So if you have a patient, an adult patient with shoulder injury or even a humerus injury, you need to start thinking grid use. If you've got a kid, a young patient, in a lot of cases you don't necessarily need a grid, but for an adult you probably do. So humerus size, shoulder size certainly, and everything that we've talked about past the shoulder, AP and the internal external rotation of the shoulder. So grid use. For the scapula, what we're going to do is we're going to abduct the arm to a right angle and flex the elbow. Basically just have the patient put their humerus at a right angle, kind of like what you were going to do for a axillary view. So in this case, though, you're going to shoot AP, and you're going to shoot 2 inches inferior to the coracoid process. Now, on the AP of the shoulder, we might not include the entire inferior portion of the scapula itself. This time we want to make sure that we include it. The purpose for abduction of the humerus is to move as much of the scapula out from under the ribs as possible. You're not going to get the entire scapula out from under the ribs. So you may think, well, abduction to a right angle is good, then putting the arm above the patient's head would even be better. And it doesn't work that way. Once you move above a right angle, then what happens is that you get a bit of a rotation of the scapula, and it becomes distorted. So right angle as far as you need to go. Certainly you're still going to have some superimposition over the ribs, but it's going to be less significant than in a straight AP of the shoulder. So collimation is going to be 10 by 12, but the length is going to be running with the length of the body to make sure that you include the lower portion of the scapula. You're going to include 1.5 inches above the shoulder, so your image receptor, just like on a chest x-ray, is going to extend 1.5 inches above the outer portion of the shoulder, and 2 inches beyond the lateral aspect of the shoulder. And you want to make sure that you include the lateral half of the clavicle. You don't need the entire clavicle, you need the entire scapula. And you can have the patient slowly breathe to get rid of some of the lung markings. So the technique that you would use for the AP of the scapula is going to be so low that you're not really going to have the ability to get like 3-second breathing technique like what you would use for transthoracic. So in things like ribs, if you wanted to have the patient breathe to blur out some of those lung markings, basically what you would do is have the patient take in a big deep breath and slowly blow it out and make your exposure while the patient exhales. So that would be a breathing technique for scapula, ribs, even though most people don't use any kind of breathing technique for ribs, but I personally have found that it's beneficial in some cases. It's not something you see in the textbook, but just have the patient slowly breathe or exhale during the exposure. So everything still applies, evidence proper collimation. You want to make sure that you've got all the required anatomy, make sure that you don't over abduct the arm, extending it past 90 degrees, which would tilt it and foreshorten it. And anyway, it should look like that. So we've got some of the scapula out from under the ribs. Looks like the patient was breathing a little bit so that it blurs the lung markings, but notice it doesn't really blur the ribs. So just kind of file that away whenever we get to ribs. I'll talk about it again then. Lateral scapula, again, same things that we talked about before, 45 to 60 degree anterior oblique. If you're shooting PA, that would be RAO or LAO. Remember, your obliques are positions, and so a RAO, right anterior oblique, the anterior side would be closest to the image receptor, so that would be a PA oblique. But again, a lot of the techs in the area like to shoot AP, so all of this would apply to the AP as well. So 45 to 60 degree angulation of the patient's body, not central ray, that will be an axial. This is just an angle of the patient's body. And it should look identical to the scapula, the Y view that we saw before, with the only exception is notice that the humerus is out of the way. In this case, it's behind the patient. In this case, it's in front of the patient. And in this case, it's straight over the patient's head. So here we've got either unilateral AC joints or an AP of the clavicle. Most likely AP of the clavicle, just to stay in line with all this. Most likely AP of the clavicle because AC joints are usually bilateral. Here we've got a lateral of the scapula. We can tell it's lateral of the scapula because we can see good Y view, and the humerus is going across the patient's body. If this was Y view for the humerus would be right over the top of the scapula. So neutral rotation, AP of the shoulder, axillary view, which is your Lawrence, your inferior superior projection. So telltale sign that this is AP of the scapula is the humerus is at a 90 degree angle. You just don't put the patient's humerus at a 90 degree angle for the AP of the shoulder. I'll be honest with you, this is kind of a mess. Collimation is way too wide open for a AP of the clavicle. Looks kind of like a neutral rotation, looks kind of like an internal rotation of the shoulder. If it is, then it's poor positioning. Central ray should be here. That is an image that should not make it into the textbook. Gracie method. Tell us Gracie method because we can see the separation between the humeral head and the glenoid fossa. We can see those two. And the clavicle looks really hideous. So external rotation, we can see the greater tubercle lateral. Y view in this case for the humerus, humeral fracture, possibly dislocated shoulder. None of those two are present here, but we can tell that because the humerus is not moved. If it was a Y view for the scapula itself, the humerus should be out of the way. So AP of the shoulder, internal rotation, we've got the lesser tubercle here, and we've got the transthoracic.